So as I've already said, this was actually technically part of the investigation on glaucoma, but that was such a complicated animal. I decided to keep this aside as something slightly different because I'm not sure a lot of community-based optometrists do it anyway. It's very much more a hospital thing. And also, I've got my reasons for not doing it at least very often, which I'll go through. And we've got a bit more time to do it then today. So you've got to look at it from the point of view of the ophthalmology department, but also why we would do it in the community. So before we move on to gonioscopy proper, I think it's important just to think about some of the alternatives we now have in in hospitals as well, but in the community. And certainly OCT, in my opinion, eliminates an awful lot of requirements that gonioscopy used to give us. And yes, I know there are certain things gonioscopy can do that OCT simply can't, but our goals in the community is simply to refer people, to differentiate people and refer on an intent to treat basis. So our goals are somewhat different to the hospital goals. And this OCT is a really good photo here. It allows you to really see the structures quite well. For instance, the TM is beautifully demarcated there. And you can see the other structures that you might be looking at with a gonio lens. So when is it in the patient's best interests to do gonioscopy? And I think that's the real point. It's got to be a point to the patient. Otherwise, you're doing something for no real reason. Is it going to change your referral from a community point of view, community practice point of view? Is it going to change your management? Now, the European Glaucoma Society suggests that gonioscopy is to determine the topography of the AC angle. So the level of iris insertion, both true and apparent, the shape of peripheral iris profile, an estimation of the width of the angle, the degree of trabecular pigmentation, that's obviously huge, and that's certainly something that an OCT cannot do. And then identification of peripheral synechia, of course. So when is it valuable to do? Well, for patients whose signs or symptoms indicate a risk of future secondary glaucoma, trauma, angle anomalies, tumours, neovascularization. Now, a lot of those things would be at the hospital anyway. Someone with severe neovascularization is hardly likely to be dealt with in the community level. And patients suspected to have narrow or closed angles. And, I may suggest that there are other alternatives to that anyway. When is it contraindicated? Patient with compromised corneas, obviously. This is, depending on how you push as well, it can be quite traumatic on the cornea. So you need to be very sure of yourselves. Current corneal erosions, corneal keratopathy, patients with certain connective tissue disorders, and obviously immediately post-trauma. So obviously initially you're going to allow the trauma to heal, then perhaps look inside to see what's going on or if there's need to. So the landmarks. Now, this is how I learnt it, how I was taught it. To remember it, I can't see that shit. And I think it does resonate. I mean, I was taught this, 20 years ago now, and it never leaves me. So iris. Now, iris strands can extend to the trabecular meshwork, but basically, when you're following it in, you're starting at the posterior, so you're looking into the eye, and you're following it back from the iris. So you start at the iris, you're moving along, then you come to the ciliary body, and it may vary in color a little bit, but it's basically pretty dark. Then there's C, the scleral spur. It's a projection of the sclera and is a distinct whitish zone. Then there's trabecular meshwork. Now that always used to confuse me. I used to get this wrong a lot. You've got posterior and anterior trabecular meshwork. The posterior, the bit you come to first if you're following it down along the iris, from the iris, is the filtering part. And that contains the Schlemm's canal. It's usually darker, and can be pinkish a bit due to the blood in it and so on. And then you come to the anterior TM, which is a non-filtering part, slightly amorphous, so on, but you know, it's slightly anterior to that. And then finally we come to Schwab's line, which marks the demarcation of Descemet's membrane. And it's the region of transition from cornea to sclera. It forms the anterior boundary of the trabecular meshwork. So they're the things that you would be looking for in a fully open angle. I can't see that shit. Now, if you're going to start doing this, you need to do it on everybody quite regularly so that you get the hang of it. Because if you go in and you try to differentiate things without having a lot of practice with this, you won't get it right. So grading, there are a number of gonioscopy grading systems, and you do have to really qualify which one you're using, because some of them are quite, or almost the reverse of each other. The one that most of us use, or I think is very logical anyway, is the Schaefer system. It's logical because for us it equates completely with the Van Herrick scheme, and you know, we're all very used to that. So basically, the bigger the number, the wider it is. The Shea system is pretty much the same as Shea, only it's the dead reverse, where IV4 is closed. So it doesn't work logically with us optometrists who are used to thinking about for the big number being wide open, the small number being closed. The Spaeth one is a very, very descriptive but extremely complicated system. And I think if you're good at it, it must be really good. With a single bunch of numbers and letters, it completely defines the angle. But you have to be good at it. And I have to say, I talked to an ophthalmologist once when I was doing a placement at the hospital. He says, oh, for goodness sakes, no, we haven't got time to do that. Just get on. So now that's one ophthalmologist's opinion, of course, but I thought, yeah, okay, great. So with the Spaeth, with the Schaefer system, grade 4 is wide open. All structures are visible. It's very simple. It's grade 3, you subtract one structure. So at this point, if you're moving from the iris forward, you cannot see the ciliary body. You can still see the scleral spur, the trabeculum, and Schwab's line. Grade 2, you're subtracting 2 structures. So now gone is the ciliary body and the scleral spur. You've still got the TM and Schwab's. And then grade 1, 3 structures are gone. And in grade 0, no structures are visible. So it's a really nice, simple, quick way of grading the angle. So when you are looking in, you should start at the most posterior part of the anterior chamber and move forward. So we start, and the layers appear as alternating dark and light bands, ideally. And as we've already said, the more layers you can see, the wider the angle. And as the layers become non-visible, in turn, as the angle narrows. So what do we got first when we're moving in? We've got the iris, that's I, and that obviously is the color of the iris, and you can just see the pupil there. And as we move forward or along the iris, we come to the ciliary body, I can't, and that obviously looks a brownish hue. Then the S, the C, scleral spur. And obviously that's a whiter color because it's the sclera. And then you come to the trabecular meshwork, and that always had me slightly confused. I always muddle this bit up. And it has the posterior, we should always be working from the posterior forward. So posterior first, that's the darker colored bit, and that is the actual draining part of the trabecular meshwork, the functional part. And then we go into the lighter color, which is the anterior trabecular meshwork. And then finally, the Schwab's line. I can't see that shit. Schwab's line, which is the transitional zone from basically from the sclera to the cornea. So, and as I've already said, you've got to look at a lot, really. You've got to look at a lot of normal eyes before you can really realistically and professionally interpret a less normal eye. But that's a theory, and if you get stuck in and practice, it all falls into place. So there's direct and indirect gonioscopy. The direct method, obviously, you're seeing the angle that you're looking at, not the opposite one, but you do need specialist lenses to do it, like you can see there. And I don't think too many people do it. And then there's the indirect method, which most of us do. There's the 3-mirror Goldman system and the 4-mirrored Zeiss system, where you're looking at the angle opposite the mirror that you're using. So the 3-mirror Goldman lens, you do have to have coupling fluid. That creates the stabilizing suction for examination, but also it creates it neutralizes the optics. If you had air in the middle, you wouldn't be able to see. And the lens needs to be rotated to view all the quadrants. So there is a certain level of abrasion going on there. But you only have one mirror for the anterior chamber. The other mirrors are used for posterior examination. So the peripheral retina. So again, it's a very, very good lens in that sense. You know, for retinal detachments and retinal tears, it's obviously only, so if you only had one gonio, this does both things. But it is time consuming when evaluating both eyes, and it's messy, and obviously patients, I don't think, particularly like it. Then there's the Zeiss 4-mirror lens. This is the one I use. I really like it. I think for beginners, it's the one to go for. Now, apparently, I was told that this has stopped being made. But I went online just before I did this talk and looked for it, and I can find sites that sell them. So I'm not sure if that's totally true, but it's a nice lens for the community, but it only does the anterior stuff. You can't look at the posterior. There's no coupling gel required because it's such a small zone. The tears pool in there, and that neutralizes the optical surfaces. And obviously, as you can see there, all 4 quadrants are visible without rotation. And the ophthalmologist that I taught me this method. You just write a cross down, so it's dead quick, and you write the number of structures that you can see, 4443. So it's very, very quick to write things down, and then you can move on. Now, I happen to use a daily contact lens to protect the cornea as well. Now, with the last talk I did with this, I didn't have time to go through this, but I did an infection control course, and it was during the time my dissertation, well, my dissertation, that's a bit broad, but was on this. You had to take something out of your practice and do an infection control analysis on it. And this was in the days of CJD. And so I decided to do this. And the bottom line was, this is basically what stopped me ultimately doing it, because we didn't have the facilities to quarantine equipment, because one of the risks, or one of the ways you could protect, was to quarantine equipment. Now, you have to have an awful lot of gonio lenses to go quarantining them for, I can't remember the exact amount of time, but you had to quarantine them for quite a long time. Because CJD being a protein, you can't just sterilize it, you can't kill it because it's already dead. And indeed, that's why I started using a daily contact lens to add extra protection when you're doing the technique, and it protects the cornea. And it works very well. To me, it doesn't muddle up the optics at all. So if anyone is interested in doing it and wants that little bit of extra protection, I would highly recommend the idea of doing the daily contact lens. But it does mess up the system again. It's adding another layer of time to doing something that you maybe want to do quite quickly. But certainly it works very, very well. But that's the thing that got me thinking about what is the advantage of this to the patient, what are the risks, and is it in the patient's best interest to me muck around with this thing? And okay, CJD seems to have died a death recently, but you know, it's still out there, and there are still other bugs that can get in. So you've got to be thinking, you've got to be doing this risk-benefit analysis to figure out what you want to do. So leading on from what I've just said about why I don't do gonioscopy, about the risk and benefits, there is a stringent cleaning regime for this stuff. So obviously you check staining of the cornea, ensure the gonio lens is disinfected, ready for the next use. So the College of Ophthalmologists guidance do not allow the lens to dry after use. Do not use alcoholic-based products. Rinse clean with liquid detergent. Rinse again for 30 seconds. Immerse in 1% sodium hypochlorite for 10 minutes. Rinse with 3 chains of saline for 10 minutes and dry with tissue and then store dry. Most manufacturers also provide advice on disinfecting of their specific lenses. So, disinfecting these things is critically important. It's, again, quite time consuming. So you want to be sure you want to do it. So when do you refer? According to this, we refer definitely when those are suspected of narrow angles. Obviously, especially if they've got visual ocular symptoms. Evidence of optic nerve damage. Right, so let's look at that first. Well, we're going to do that without it, aren't we? If there's visual symptoms, and then if the Van Herrick's is very narrow, then yeah, I would say we're going to be referring anyway, especially if there's visual symptoms. And obviously, if there's evidence of optic nerve damage, then you're going to refer anyway. Probably those with suspected closable angles, especially if they're hyperopic or if there's a family history. And again, in that situation, I think an OCT can fulfill the roles that we require. Or if only half or less of the trachea is visible in all 4 quadrants, then the eye should be considered at risk of angle closure. The main thing that we can't do, in my opinion, is check for the pigmentation of the trabecular meshwork. But again, if you've done your full assessment anyway, and the pressures are somewhat high, and you open the pupil up and you realize that there's pseudo-exfoliation, or if there is pigmentary dispersion syndrome, then frankly, there's the evidence there in the anterior chamber without actually looking at the level of pigmentation evident in the trabecular meshwork. So on the whole, my general consensus is I don't believe we need to use it. I think the FAF and the risks of infection and so on are greater than the benefit we get from it. Also, it's not unusual for me to use provocative testing anyway. I'm not averse to that. And if I can create a provocative situation where I can induce an IOP spike, then that's evidence that the angle is closable as well. So you've got to do your own maths on this. You've got to do your own risk assessment and decide whether you personally want to do it in the community. My decision is not to. I'm not saying that should be yours. So thank you very much for listening.